A very good evening, everyone. We'll start the session in a couple of minutes. Very good evening, everyone. We'll start the session in a couple of minutes. We request you to stay edu, please. A very good evening, everyone. We'll start a session at 7:30 sharp. We are extremely sorry for the delay.
Hello.
Good evening, sir. Could we start the
Good
session,
evening.
sir?
Yeah, yes, I can start the session. I'm sorry,
Yes,
I could not join in time because I had a close family member who had passed away. So I need to come to my native place. So I'm just joining from my car. I'll be briefly on this link. Okay. So we can
totally.
start the session. I'll just start the session.
Okay, sir. So, a very good evening, everyone, and welcome to this insightful session on hemato-oncology. I'm Roshni and from International Association for Integrated Oncology, IAIO. I warmly welcome to today's session of expert insights on hemato-oncology. It's my pleasure to introduce the program director for today, Dr. P.K. Jayachandran, consultant medical and hemato-oncologist at Apollo Cancer Center, Chennai. Dr. Jayachandran will begin with an introduction and setting the stage for the today's deeper discussion. Sir, over to you, please.
Yeah. Thank you very much for your kind introduction. So I not prepared any slides for the introduction of the CLL. I just wanted to have a quick review because I had an emergency which I had to leave for. So CLL is a chronic malignancy, and in most of them nowadays, due to the availability of the master health checkups, we have a lot of patients getting diagnosed in an asymptomatic stage, and then we do keep them under follow up. Uh, we do keep them under follow up, and then we keep under observation surveillance. Once they become symptomatic, we start treatment, and from the era of continuous treatment, we have switched over to finite treatment era, and the treatment paradigm has switched largely in the last 1 decade from what used to be like chlorambucil rituximab for FCR in younger fit individuals. And then subsequently, we had these ibrutinib, BTK inhibitors coming into the picture. And then the venetoclax came in. And then now we have combination agents of acalabrutinib, venetoclax. We have the venetoclax rituximab combinations. We have venetoclax obinutuzumab combination. The most recent one is the acalabrutinib venetoclax combination, which is going approved by the FDA. And then we have something more to come, like the triplet agents, which are all going to be there in some time. So what we are looking, what was something like symptomatic disease response. Now we have moved to uh, sort of MRD, looking into MRD in CLL, again IPI in CLL. All these things have changed in the last 1 decade, and a lot of updates have come in. And the second topic of the day is going to be from Hodgkin's lymphoma. I think it will be a wonderful thing because we have the generic nivolumab in India, and I think we will be able to offer the generic nivolumab to a lot of patients now. And also, we shortly expect the generic brentuximab by the end of this year as well. So we would have both the brentuximab and the nivolumab available for most of our patients by the end of this year. Already we have nivolumab, and by the end of this year, we will have the brentuximab as well. So I think we would have all the armamentarium available for patients at this point of time for Hodgkin's lymphoma. We would love to uh, we would love to hear from the speakers and also from the panel discussion members, moderator about the CLL and Hodgkin's lymphoma. I would like to switch hand over the session back to IAIO to introduce the moderators and the speakers for the sessions. Yes, I would be on the mute mode. I've joined. Thank you very much.
Thank you. Thank you, sir, for that insightful overview. We now move on to the panel discussion. I would like to invite the moderator, Dr. Krishna Chaitanya Sir, Associate Professor, Medical Oncologist, MNJ Institute of Oncology, Hyderabad. Along with, I welcome the distinguished panelists, Dr. Prashant B, Consultant Hematologist and Head of the Department of Adult Hematology, KMC Hospital, Mangaluru, Dr. Rohan Haldar, Consultant Hemato-Oncologist in Bone Marrow Transplant, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Now I would like to hand over the section to the moderator, Dr. P. Krishna Chaitanya, sir. Sir, over to you, please.
Yeah.
Before we begin the panel, I request all the faculty to turn on the cameras.
Thank you, Roshni, for that kind introduction, and the panelists are my. I hope my screen is visible and I'm audible. Can anyone
Yes,
confirm, please? Yeah, right.
yes,
Thank you.
Dr.
So, I'm going to talk about the CLL. I'm going to moderate the session, and the expert panel is there. They would be answering the key questions and what is the clinical practice now. So, the topic would be on optimizing the patient journey in CLL. That is the shifting gears from the infinite to the finite therapies. I would welcome again Dr. Rohan and Dr. Prashanta for the session. And this is the disclaimer. We know that CLL we don't treat, like acts, I know Jaychandran was talking about, like, asymptomatic we don't treat, but when there is a indication for treatment, we are going to start the treatment. So what are your goals of therapy while treating a newly diagnosed CLL patient? Let me start with Dr. Rohan.
Yeah, good evening, everyone. So we basically look at elevating the symptoms that are due to the CLL first. The symptoms, if there is anemia, thrombocytopenia, if there is any B symptoms that are ongoing, like to treat that. Also evaluate for if there are B symptoms, evaluate for any infections that could be undiagnosed, any immunoparesis that is there, which is unlikely in treatment naive CLL. Also, we would like to get a good disease control using whatever therapies that are available to us. With this, obviously, depending on what therapy and what are goals of the patient, I mean, what kind of therapy the patient which wishes to, start on, whether it is a time limited or just a definite, 1 year therapy, or if the patient wishes to stay on continuous therapy. We discussed regarding what are the goals of treatment and what would they want if they want to stay on treatment. They don't mind staying on treatment for a very long time if they're okay with that. Also, we give them the option of completing the treatment, say for about 1 year, and then being off treatment and be again on observation like other patients do. And with that, we aim to get good disease control. And with that, hopefully, this will also lead to prolongation of survival and also will improve the quality of life. And obviously, with that, we expect that the quality of life is maintained, uh, and uh, and obviously we can hopefully get a sort of a functional cure in this group of patients. So depending on that, we choose our therapy.
Right. Totally accepted. And Dr. Prashanta, anything to add on? Any additional points?
Yeah, I think we are in a very interesting phase in India as far as CLL is concerned, because we know that we have increasing data regarding, efficacy of BTK inhibitors and BCL2 inhibitor combination and finite therapy and all those things. But if we actually look at the actual practical point of view, probably 10 to 15, maybe up to 20% of our patients would be able to afford this kind of treatment at present with the current pricing of the drugs. Rest of the patients, we are a lot of the patients still come under your Ayushman scheme, Prime Minister scheme. So there, these treatments are not yet available. We have to fall back to bendamustine rituximab or FCR-based chemotherapy still. So it's kind of an interesting phase. So it's become very difficult, once a patient comes to you, you don't know what is his financial status, what is his uh, treatment expectations. So earlier, at least we had a chance. You take this chemotherapy. If you are lucky, you will survive. Otherwise, no. But now we have so many treatment options. So CLL, we have to spend at least half an hour to 45 minutes with each patient to make them understand what are the pros and cons of this treatment, and then help them to decide what is the best treatment option that is available. So it's changing, and we are also probably adapting ourselves.
Yes, totally agree with both of you. I think now the goal is like to have a good disease control and with quality of life and prolonged survival. That would be our goal in starting the treatment of CLL. And regarding the treatments, I think we are totally come out of that chemoimmunotherapy because of availability of the drugs. Of course, now even I work in a state government institute where we are able to provide the BTK inhibitors to all of them, all of them. And whenever there is a chance or to add a venetoclax, that we are doing. So that is the routine practice right now, and we have totally come out of chemoimmunotherapy. That is the bottom line. And to start again with Dr. Prashanta, can you just, what are your factors when you consider the treatment? You were talking about the how we are moving, ahead with, keeping the chemoimmunotherapy aside, the newer molecules. So what are your factors? So can you just brief on that?
Yeah, so it mainly depends on the patient profile. Whether the patient is a young patient or a old patient, and also what are the comorbidities that the patient has. Is the patient physically fit or not? If the patient is somebody who is physically fit, young patient, obviously we would try to give a fixed duration treatment, try to get a CR and put them into some kind of CR and give them a treatment-free remission. That would be the goal. But somebody who is little elderly, kind of have some comorbidities, difficult to tolerate 2 drugs or 3 drug regimens, you just put them on a single drug BTK inhibitor and just, continue the treatment as long as they are alive. Many times these patients succumb to their comorbidities rather than CLL. So again, as I told, of course, earlier we used to discuss about the disease biology, TP53 mutations, IGH mutations. But I think in the current era of BTK inhibitors, especially with the acalabrutinib freely available in India, they don't matter so much. You just, irrespective of the disease biology, you start them on acalabrutinib and continue.
Yeah, totally agree. Even our clinical practice is the same. So as I said, all of them would require BTK inhibitors, and wherever the venetoclax is available, where we can do a fixed duration, definitely that would be the preferred treatment option. And of course, we are still keeping the genomics, the biology of the disease, also in the initial risk stratification, whether it's a mutated IGHV or not, or presence of P53 or deletion 17p. And Dr. Rohan, anything to add on this?
Yeah, I think Prashant has summed up the whole thing well. I think he sums up everything. I mean, there's nothing much to add. I mean, basically one thing probably where I mean the only probably what I can think of is with obviously acalabrutinib availability has changed the way at least even we practice over here. I mean, at least ever since um, I mean, in the last 5 years or so, we have not given immunotherapy for CLL. I mean, maybe barring bendamustine and rituximab in few of the patients, but hardly ever use FCR. So that has been a big change for me. I mean, when we were training, we were all we were using either FCR or BR, but until in the last 4 5 years, hardly ever use FCR. BR still okay. We still end up using in few of the patients. That's again, numbers that you can just count by hand. I think nothing much to add.
Right, yeah. Agreed. So the basic factors would be the disease biology and the genomics, what the patient wants, is it a fixed duration or a continuous BTK inhibitor? Of course, that would be decided on the disease biology and the genomics, and what the available options, the treatment efficacy and the safety profile, which is more important when you are using a drug which is like a continuous lifelong. The safety profile comes into place because as the adherence to the treatment is more important to keep the disease under control. If they are non-adherent, again there will be a problem of the disease relapses, and with the newer mutations where we can't control the disease with the available drugs. So that is a problem with the long-term treatment, and the safety profile should be very important, like where you are able to manage the side effects effectively. So in your practice, Dr. Rohan, is the CR and undetectable MRD is your goal, or is just the prolonging the survival and keeping the good quality of life disease control is sufficient, or you want a CR or a MRD in your practice? And is there any patient subset where you are looking into it?
Actually, in our practice, not really aiming to achieve an undetectable MRD either on peripheral blood or the marrow. Are more, I mean, the more important goal is to ensure that the patient's disease symptoms are in a fair degree of control, and the patient can have a good functional activity and can have good functional reserve if the patient is very elderly. um, in any particular subset, if I have to say, if that would be in patients who are going for fixed duration therapy, probably there I would be more keen in, say, using in looking at undetectable MRD. But again, that is a question, which has a lot of caveats to it, and
Right.
a lot of other things, that remain unanswered, till when you want to keep the undetectable MRD, and, when do you again start treating once the MRD begins to rise. These are, or do you wait for a full-blown disease, when, you once again all the treatment criteria are met? Or do you wait till then? Obviously, most of us would do that if you want the patient to keep enjoy a treatment free remission kind of thing. So otherwise, we are not using,
Right.
we are not trying to aim undetectable MRD or CR per se.
Yeah.
We're quite
Yeah.
happy if the patient has a
Got it.
good functional cure.
Got it. So at present, we are routinely not doing it. Probably in future, we are going to do that, especially in a patient of poor prognostic biology, like the unmutated IGHV, where you are using a fixed duration, as you are saying, and maybe when to stop it. If there is MRD is detectable, maybe we should continue with some kind of the treatment rather than stopping it. I think MRD guided treatment is going to come up. Of course, now we are not routinely doing it, but in future, that would be the treatment of choice for a subset where they have a poor prognostic markers and not achieving the MRD at the end of the fixed duration treatment. And Dr. Prashant, then what about your, is it like very important, the treatment-free interval? Like, how you do a TFR in CML. So is it also important in CLL, the treatment-free interval? What's your take on that?
Yeah, definitely. Somebody exactly after 1 year, 2 year, the first question they ask is still how long we have to continue, sir? Can't we stop? In the beginning, we would have counseled them, we would have told them, no, Baba, you have to take it lifelong. Still, after 2 years, they have a fatigue that is setting in. So they just want to kind of stop the treatment. So they're, repeatedly, every follow-up, they come and question, can we stop the treatment? Can we stop the treatment? Can we reduce the dose of the treatment? Because ultimately, I think, even with the freely availability of acalabrutinib also, we are looking at least 15 to 20,000 rupees per month expense, which is not a easy thing for long term, 5 years, 6 years, 10 years. This cost of it's just like, when we were giving initial times, Gleevec was freely available and only Sprycel and Tasigna were available. That kind of a situation. So definitely treatment-free remission is something important, but especially for younger patients.
Right, correct. Of course, yeah. So the treatment-free interval is very important in CLL patients in the clinical practice. As you know, the panelist, Dr. Prashant was saying, even the financial toxicity also is much less when you are choosing a defined fixed duration treatment, because we are going to have the same PFS, whether it's a fixed duration or a continuous BTK inhibitor. And of course, it's not just the financial thing, the toxicities what we are going to get with continuous treatment, and of course, the development of the resistant mutations, which we can avoid by doing a fixed duration treatment, because there is an option for again retreatment with the same regimen when they have a relapse again. So fixed the treatment free interval is very important in whatever disease it is. It's very important. So patient wants that break. Even in the solid tumors metastatic setting, patient will be asking us, but we will be scared to stop there. But at least these are the chronic leukemias where we have the privilege, or we have the luxury of stopping the treatment with the availability of the treatment regimens. Right. So these are the patient preferences which we are talking about. Everyone wants a fixed duration treatment. They don't want to be on long term because of the pill burden or the comorbidities, the drug-drug interactions. Everyone wants to finish off that treatment. At least they'll have at least a 6 to 7 years of treatment-free interval when you are choosing a fixed duration treatment. Even the physicians also would like to do that. So here is the patient case. I'll summarize the case. He's an elderly man, no significant prior medical history. He was on follow-up for a asymptomatic CLL. After 3 years, he developed symptoms. So now we have to start the treatment. The baseline laboratory results have shown that there is a mutated IGHV. There is no deletion of 17p or p53. There is already a thrombocytopenia. So for this patient, Dr. Rohan, what would be your treatment of choice? With these options available, it is a mutated IGHV, to repeat, and you want a BTK inhibitor or a fixed duration of treatment or any other treatment in your clinical practice?
It's quite elderly, so I think I'm quite happy to stick to BTK inhibitor and the second generation, obviously.
Okay. Just a minute. Sorry, there is a call. So what about Prashant? What's your take on that? Mutated IGHV, because now we choose the treatment based on the genomics of the biology of the disease. So what's your preferred option in this?
Yeah, it's an interesting one. You have a good risk CLL, so, and relatively young fellow with no comorbidities, major comorbidities. So definitely TFR would be a picture factor here. So a dual therapy with when BTKI would be a first choice for me, because when anti-CD20, the problem is that we don't have a data of when Ritux. We have only data with when and obinutuzumab.
Right.
And obinutuzumab is much more expensive, so it becomes little difficult to push it upfront for a period of 1 year or 2 years. So it becomes little more reasonable for us to push when BTK, especially when acalabrutinib, for this kind of patient.
So totally agree. So the mutated IGHV, basically the biology is good. They're going to live longer. So when you're starting a continuous treatment like BTK inhibitors, it's like, longer treatment. And the evidence what we have with the fixed duration of when BTK or when anti-CD20 is, because the PFS is much better compared to the continuous BTK inhibitor. So mutated IGHV, the preferred choice should be a fixed duration treatment because they are going to do well. So we don't want to keep them on long-term treatment. Just do a fixed duration of 1 year of treatment, and of course they are going to have a very good progression-free survival. So when BTK inhibitors would be the preferred option, and of course with the acalabrutinib when combination. So this is the data what we have with the CLL17 study, where they have randomized into 3 arms: a continuous BTK inhibitor, or a fixed duration of when obinutuzumab, or when ibrutinib. So the median observation time was around 3 years. It was a non-inferiority study where we have the compared with the 3 arms, the fixed duration versus single agent of ibrutinib, or a BTK with venetoclax fixed duration versus ibrutinib, which was a non-inferiority study. And the outcome, this is the study results. You can see the CR rates in a mutated IGHV, or we can see in this study, the single agent of BTK inhibitors are giving only 10% of CR rates, where you can see the fixed duration is almost reaching 50%. And MRD rates is like excellent, like 50 to 70% when you're using a fixed duration combination. And the PFS rates, of course, they are similar. Even unmutated also they have similar. Even with TP53, it's similar. Maybe the BTK inhibitors, they do well with the deletion 17p or p53. So, and hence, if the patient is having a mutated IGHV where they are going to do well, it's always better to use a fixed duration of therapy. And if the patient is having a TP53 or deletion 17p, definitely they require a BTK inhibitor, either a single agent or a combination of a fixed duration. So this is the the bottom line of this slide. So, and of course, the side effects we expect more with the obinutuzumab combinations, and the cardiac disorders are more common with the BTK inhibitors. That is with the first generation like ibrutinib. But now the present second generation like acalabrutinib or janubrutinib, the cardiac disorders are much less. So now, if you are choosing a BTK inhibitor, it has to be acala or janubrutinib. Avoid ibrutinib because now acalabrutinib is available as a generic molecule. And wherever it's possible, you have to do a fixed duration treatment with venetoclax and BTK inhibitors. So to conclude, this study has shown that it is non-inferior. The combination, fixed duration combination, is non-inferior to continuous BTK inhibitors. And CD20 antibodies will have a lot of toxicities, the infections. And as rightly pointed out by Dr. Prashant, we don't have a data with venetoclax and rituximab. It has to be obinutuzumab, which we are not in favor of. The preferred would be a venetoclax along with acalabrutinib. So the fixed duration is the primary option in mutated IGHV. That is a take-home point for this case. Mutated IGHV, try to give a fixed duration. If not, then the second option would be a continuous BTK inhibitor. This is the mutated IGHV state, the various studies of this subgroup. We can see the BTK inhibitors are giving around 6 years of PFS of around 70%. All of them are similar. We can remember around six years of PFS of around 70%. In combination, the fixed duration also will give the same PFS. So it is similar. It is non-inferior, where we are continuing this BTK inhibitor lifetime, whereas here we are doing a fixed duration therapy. Even the combination of venetoclax and BTK inhibitors, it is also similar, like 6 years of 70% of PFS. And even with combination of venetoclax and acalabrutinib, the study period is less, but we can expect around 6 years of PFS of around 70%. So we are going to have a non-inferior results with the combination compared to the continuous. And of course, there is a fixed duration. So I'm sorry. So fixed duration, we are going to save on side effects. We are going to save on finances in mutated IGHV. The preferred choice would be a fixed duration, venetoclax and BTK inhibitors. So coming to the side effects, as we are discussing, the BTK inhibitors would cause the cardiac side effects and the bleeding manifestations much more common with ibrutinib, whereas you can see with acalabrutinib combination, they are much less. So when you're using a BTK inhibitors, always prefer acalabrutinib or janubrutinib based on the side effect profiles. So this is the treatment-free interval, what we are going to get with the fixed duration of venetoclax and either obinutuzumab or BTK inhibitors compared to the comparator arm of chlorambucil or your chemoimmunotherapy, which are obsolete now. We are not going to use it. But in this study, they have shown that there is no doubt the hazard ratio of 0.3, 0.4 clearly superior. So the problem with continuous BTK inhibitors is the development of these mutations, like how we have seen in the CML. So we have a C481S, which is commonly seen mutation when you are using this covalent BTK inhibitors, that is ibrutinib, acalabrutinib, and janubrutinib, because these agents are going to act at this site of ATP binding site. This is the site where they are going to act. So the mutations occur in this the most common, whereas the other mutations are also seen with the covalent inhibitors and as well as with the non-covalent, the pertubrutinib, which is the recent molecule which we are going to use in the relapsed
Hello. Dr. Chaitan, you are not audible. Hello.
So you're not audible.
Not audible.
Hello, sir?
I think he's not able to hear us also. I think it got stuck, I think.
Okay, sir.
Just wait for 1 minute. Hello. Dr. Geetanjali?
Sir, we have messaged sir, like we are, I
Message,
think there's
sir.
some glitch in sir's.
Yeah,
profile.
that's what. That's something.
Sir will be rejoining in a minute. He's
Okay.
just responding.
Yeah.
Okay, I'm very sorry. There was a phone call, then I missed it. Let me share my screen again. So I hope I'm audible.
Yes, sir.
Yeah. So this is the guideline of ESMO 2024. Guideline of 2024, where a mutated IGHV. Am I audible?
So, yes, sir, audible.
Yeah. So ESMO
Yeah, audible.
2024 guidelines say that it's a mutated IGHV. The treatment of choice is a fixed duration. I'm repeating again, the fixed duration venetoclax BTK inhibitor should be the preferred choice. If they can't give venetoclax for any reason, the BTK inhibitors would be the second preferred choice. Even the NCCN guidelines also mention the same thing, and the preferred choice would be a combination regimen, fixed duration combination regimen. So when you use the first line therapy of fixed duration therapy, when do you want to re-challenge? Dr. Rohan, can you take this? So is it like you'll choose a patient who has progressed after 2 years or after 1 year, or you don't want to re-challenge again? Can you just give the
Yeah,
answer,
you can
Dr. Rohan?
re-challenge. You
Yeah,
can reach.
yeah,
You can
yeah,
re-challenge.
yeah.
I mean, that would be, you could use the same regimen actually.
Right.
If you use whatever, if you use BTK inhibitor or a venetoclax based therapy, you can use that. And again, when the patient becomes symptomatic, when he fulfills the criteria for treatment, that time.
Right. So that is a reason why we are going to choose a fixed duration, because there is a chance that we can use we can re-challenge with the same drugs, and we are going to get a good treatment-free interval in between. So Dr. Prashant, what about chemoimmunotherapy? I have stopped using this at all because now we are going to get a BTK. No, I'm getting the BTK inhibitors in the state health scheme also. So wherever the venetoclax is available, I'm going to use a fixed duration, otherwise a BTK inhibitor. Chemoimmunotherapy, past 4 years, I haven't used even for a single patient.
Yeah, bro, right now I have stopped treating these scheme patients. Since last 4 years, I haven't treated any scheme patients, but my colleagues do treat. And in Karnataka, it is not, the acalabrutinib is not yet approved for CLL. So for CLL, they are still they are forced to use BR regimen.
Okay.
Now, if you see, the question is there any role of chemoimmunotherapy for any patient for that matter? If you see in a realistic world, absolutely no. If the patient doesn't have any money, if there is no other issues, nothing, you just give acalabrutinib and venetoclax combination and get away with that. But when the patient can't afford these kind of drugs, even with the acalabrutinib, venetoclax right now, 1 year therapy would cost something like 16 to 15 to 16 lakhs. There are some patients who cannot afford and they have mutated IGHV mutation. So we end up giving BR regimen, telling that there is a chance of development of mutations over a period of time. There is definitely the chance that there is relapse, and if they agree, we sometimes push it. But that is specific to our kind of population that we deal with. Otherwise, in an ideal case scenario, ideal world, there is no role for CID.
Right. So chemoimmunotherapy, the PFS rates are lower. There are toxicities, secondary malignancies. So better to avoid chemoimmunotherapy and development of these mutations also. You can compare the venetoclax at the baseline and the chemoimmunotherapy. So you can see the development of the complex karyotyping when you're using a chemoimmunotherapy compared to the venetoclax. And the mean chromosomal aberrations also. There is no change with venetoclax, whereas if you are using a chemoimmunotherapy, it is going to double. Your complex karyotyping is going to double. So, Dr. Rohan, a patient with elderly, again having comorbidities, preserved renal function, and think that he is a mutated IGHV. So, what would be your treatment of choice?
Sure, this is 74. I thought the last one I read it as 84. Okay, so here, BTK is like, stick to BTK inhibitor.
Okay. The option would be a fixed dose, if not, maybe a BTK inhibitor. I totally agree with you.
But then again, there is second data for this one. Venetoclax in combination with rituximab from the CLL13 trial, where it
that
is
is relapse
shown that
setting.
it has no, that's in the upfront setting in the Gaia trial. That is the CLL13 newly diagnosed. They compared.
Right.
So there actually it was almost similar as as chemoimmunotherapy. It was, but definitely obinutuzumab is a better anti-CD20 when compared to this one, rituximab.
Right.
That's what it was there in the trial.
Correct. Because it's more selective, it's more efficacious, the obinutuzumab. And CLL, we know that the CD20 expression is very low. So we need to either use a higher dose or with a more efficacious CD20 monoclonal antibody. Regular dosing or regular molecules won't help. Right. So coming to the second patient, let us be quick. So this is a similar kind of case presentation where the patient is having an unmutated IGHV. What we see, unmutated IGHV and no deletion 17p in almost like 50 to 60% of the patients, where they don't have mutated IGHV, where they don't have a mutation in deletion 17p. This is a major chunk of the population, what we see in clinical practice also. So in this patient, what would be your treatment of choice? Let me start with Dr. Prashant. So earlier case, you were choosing a fixed duration. So what would be your preferred choice in this setting?
Here again, my choice would be to go with acalabrutinib as a fixed duration therapy. If the patient can't afford, or if he tells, okay, I am okay, comfortable with continuing with monotherapy for long term, then acalabrutinib will be the second. Monotherapy acalabrutinib would be a second choice treatment.
Right. So the data what we have is again to remind the mutated IGHV had a 6 years of PFS of around 70%, where these are going to do little less because it's an aggressive disease. Unmutated IGHV is an aggressive, where the 10% less PFS compared to the mutated IGHV. And you can see the BTK inhibitors are having around 60% of the PFS at 6 years, and obinutuzumab combinations are underperforming in this group. But when you combine with the BTK inhibitors, the venetoclax with ibrutinib, again you are going to reach around the PFS rates. The more important in this group would be MRD guided therapy. The recent trial, the FLAIR, has shown that the 5-year PFS of 94%, which is like more 30% more with the regular medication what we are going to use. So here we have both the BTK inhibitors and the fixed duration combination are again giving the same efficacy results. And of course, the MRD guided therapy would be the future thing in this, because to improve these PFS rates. And the Amplify study with a combination of venetoclax acalabrutinib, you can see almost like it's a shorter follow-up, but they will achieve almost like 60% of 6-year PFS. So in this setting, especially in this subgroup, I would prefer in future the MRD guided therapy, even though we can prefer a fixed duration or a continuous BTK. Both are the options in this case, but MRD guided therapy should be the feature, the direction. And the study also showed the similar PFS. You can see the fixed durations and the continuous BTK inhibitors, the 3-year PFS in unmutated IGHV is similar. So we have both the options available, but you can discuss with the patient. If they want a fixed duration, go for fixed duration. If they don't want, you can go for a continuous BTK inhibitor. So this is the guideline what we have with ESMO. The fixed duration is a preferred choice. Other one would be a BTK inhibitors. Both are acceptable in this case. Dr. Prashant, what's your take on this?
Yeah, I think that is fair enough. We are looking at a high risk disease here. 100% the chemoimmunotherapy is not going to work. And monotherapy with the acalabrutinib or ibrutinib per se has shown increased incidences of resistance. So definitely we have to go for a combination therapy here. Acalabrutinib, venetoclax probably would be the way, because if you see the resistance pattern, the patients who had received venetoclax in that subgroup, the resistance was very, very less. So what we have to see is that, whether the resistance that are developing to acalabrutinib can be negated by the venetoclax. We will have to get some more data on that. But it looks like, addition of venetoclax also helps in reducing the resistance levels. So in this kind of patient, as you told, MRD guided venetoclax acalabrutinib will be the way forward.
Okay. Yeah, totally agreed. And Dr. Rohan, is the same patient, is a fit 50-year-old, and do you prefer a triplet or MRD guided therapy, unmutated IGHV? Is it like a doublet, triplet, or MRD guided therapy? What would you choose? If not now, at least based on the evidence what we have, what would you like to choose?
I mean, you would still do for IGHV unmutated, though it did not show any significant difference between mutated and unmutated in the CLL17 trial. So I would still go with BTK and Ven combination, but for a limited duration.
Limited duration.
MRD guided, we are not, fixed duration.
Yeah.
And triplet is going to be a little, it's going to be a little difficult, because I think there'll be a lot of toxicity.
Yeah, it's much better to do a MRD guided therapy rather than triplet. That's what I feel personally. Maybe a fixed duration venetoclax, BTK, and do an MRD and then continue the treatment, because those two are like we can easily manage those side effects. So coming to a last case, which is a deletion 17p or TP53 mutant. Dr. Rohan, so what would be your preferred choice here?
This is a difficult one, though. Again, in the CLL17 trial, it was Ibru plus Ven, so it'll be a combination therapy. But still, the data was not powered enough to say that you can do a fixed duration for a TP53 or a 17p deleted patient. So we don't know, but it will be, I think, probably again maybe look at MRD and maybe de-escalate treatment. That's what probably that is one way of looking at things, but it'll be difficult to just stop treatment. as of now.
So what we have to understand is deletion 17p or TP53, definitely they require BTK inhibitors. There is no doubt. Either a single agent or a combination, we have to use a BTK inhibitors in this population. So these are the trials. Various trials have shown a PFS, again 6 year of PFS of around 60%, where your obinutuzumab is underperforming. So we have to add a BTK inhibitors, even it's a fixed duration with venetoclax with BTK inhibitors, or a single agent of BTK inhibitors to get these PFS rates. So BTK inhibitors in deletion 17p or p53 is a must. There is no doubt about it. So this is the data what we have with the deletion 17p, the 3-year PFS data, where BTK inhibitors are doing well, or a fixed duration also, it's a similar rates of PFS. So the guidelines also say that you use a BTK inhibitor, either a single agent, or if they want a fixed duration treatment, you can add a venetoclax to that. So the bottom line is BTK inhibitors is the most important thing in p53 mutant population. This is the NCCN guidelines also, they give them options, but the important thing is addition of a BTK inhibitors in this population. The factors what we are going to guide us, which is going to guide us in treatment decisions, would be your genomics, which we had discussed. A mutated IGHV, this is the green, that means give the fixed duration treatment. Don't treat them continuously with the BTK inhibitors. Just give them the fixed duration, they are going to do well. Unmutated IGHV, you have both the options, either a continuous treatment or a fixed duration, but the preferred choice would be a fixed duration and MRD guided in future. Whereas deletion 17p or TP53, BTK inhibitors are the most important. If they want a fixed duration, you add a venetoclax to the BTK inhibitors. The second factor would be the treatment related logistics, where the patient needs a fixed duration or a continuous treatment, that you can choose the drug. The most important would be the side effect profile of these agents. The patients with BTK inhibitors, they are going to have a cardiac bleeding manifestations or hypertension, which is much less now. So much less now. If the patient is having a BTK inhibitor, they're going to have a cardiac risk or a bleeding. So, and it is much higher with ibrutinib, but much less with acalabrutinib, janubrutinib. Safely you can use it. But the TLS risk is with the venetoclax. So there the BTK inhibitors would be preferred. So we need to remember the side effect profile of these two class of agents. And of course, the CD20 antibodies will have an infection risk and febrile neutropenia. So with this, I would like to thank once again both the panelists, and just to summarize, genomics plays a very important role in treatment decisions, apart from the patient related factors and the treatment options available. Based on the genomics, mutated IGHV plan for fixed duration combination regimen. Unmutated, you have both the options. You can choose based on the patient's comorbidities and the patient's will and wish. Whereas the mutated TP53, BTK inhibitors are the best treatment, and you add a venetoclax if they want a fixed duration treatment. And don't forget about the side effect profile of these drugs, and the newer agents of BTK inhibitors are very safe compared to ibrutinib. And venetoclax, the TLS and all, we can easily manage by escalating the dose, and which we generally we don't see in CLL at all. So with this, I would like to ask the panelists for their final words. Both Dr. Prashant and Dr. Rohan, please give your final words on this.
Yeah, I think you have summarized well. What I can just tell is that probably, couple of years down the line, zanubrutinib venetoclax combination would be a mainstay of treatment for all patients of CLL who can tolerate the treatment, irrespective of genomics, because that looks like, that category is overcoming all kinds of resistance and showing a very promising results.
Yes,
so
and now we
have.
Yeah, now we are getting even BTK degraders also. That is the new ASH thing. Yeah, of course, a lot of molecules are coming up. Totally agreed. Yeah.
So as of now, we have to adjust with venetoclax and acalabrutinib, which is still a very good combination as opposed to whatever we had in our armamentarium earlier.
Yes, totally agreed. Yes. Dr. Rohan, yes, your final take.
Yeah, I agree that fixed duration treatment have changed the landscape of treatment of CLL. There are a few things that are important, which I would still like to keep a watch on, because the CLL 17 trial that was presented in ASH and published in NEJM they have, only it's just that, the about 65% of the patients were able to, sort of complete the median time of the treatment. So I'd still like to see the longer follow-up and, would like to see the, longer follow-up and the results if they're still holding up in the long term, in the
Right.
long run. And secondly, as Dr. Prashant said, zanubrutinib will be the go-to BTK inhibitor in future because of the lower cardiac toxicity. The risk of AF is reduced by about 71% in the long run. With ibrutinib, it is when you start off, it's about 10% slow, and when you continue, ibrutinib, it's in the range of around 16 to 20%. But the reduction, the risk reduction is much higher with zanubrutinib. So I think we'll be seeing more zanubrutinib studies, and
Right.
probably we'll have to see, in the high risk population like TP53 and 17P, these populations will have to see whether fixed duration is really possible or not, because this is something which is something exciting, and if
Correct.
you can do for this high risk population, it'll be good.
Right, right. Totally agreed. So with this, I would like to end here, and I thank the Abhi for giving us the opportunity. And I would hand over the session to next speaker. Thank you.
Thank you, sir. Thank you for insightful discussion. Any of the participants having any query, drop your query in the chat box. And we now move on to the next talk. I invite Dr. N. Tejaswa, Assistant Professor, Department of Medical Oncology, Nizam's Institute of Medical Sciences, Hyderabad. Over to you, sir.
Hi, good evening.
Good evening, sir.
Can I share my slides?
Yes, sir.
Okay. Are my slides visible?
Yes, sir, visible.
Okay. Good evening, everyone. So today I'll discuss about how we have to treat an Hodgkin's lymphoma in 2016. So I'll discuss about two cases. So first case, these are two real world cases. So the first gentleman is a 22-year-old male. Is presented to us with 8 months history of progressive swelling on the right side of the neck. So on examination, it was found to be on cervical lymph nodes, and he is not having any B symptoms. So excision biopsy is the first one which we have done for him. So excision hemogram was normal, and excision biopsy was done. That is showing a classical Hodgkin's lymphoma mixed cellularity type. And FDG PET, sorry, it is an FDG PET, and it is showing an stage 2 disease, bulky. So he is not having any B symptoms. It is a stage 2 disease, bulky disease with involvement of 3 lymph nodes, 3 sites of lymph node, that is bilateral cervical, and also he is in a subcarinal lymph node. And he is also having an elevated ESR. So when you come across these kind of patients, stage 2 disease without any B symptoms and a bulky disease, the first thing we have to see is whether this patient is having an unfavorable risk factors are present or not. So these are the 3 scores which we'll use commonly, as we all know, that is German's Hodgkin study group, and also EORTC and NCCN. These are the 3 commonly used risk factors. As our patient is having an elevated ESR, that is more than 50, irrespective of presence or absence of B symptoms, it is considered as a risk factor, and this patient is considered as a stage 2 unfavorable. And he is also having 3 nodal reasons were there. According to German's Hodgkin's, it is going to be an unfavorable, and he is also having a bulky disease. So overall, our patient is having a stage 2 unfavorable Hodgkin's lymphoma. So we all know that stage 1 favorable Hodgkin's lymphoma will give 2 cycles of ABVD followed by 20 grays of 20 grays of radiation, that is based on the HD10 trial. So now how we'll treat a unfavorable Hodgkin's lymphoma. So the evidence for a treatment in Hodgkin's lymphoma starts from HD11 trial. So where the patients with the risk factors were randomized to 4 arms. 2 arms were given ABVD and 2 arms were given BIACOP. And they are given different doses of radiation, 30 gray, 20 gray, and 30 gray, 20 gray. So the outcome of this trial, if you see, so the PFS, if you in the ABVD arm, and when compared, so ABVD when compared to BIACOP. So first you will see we'll see 30 gray arm. So if a patient is receiving 30 grays at the end of the 4 cycles of chemotherapy, there is no difference in a progression-free survival. Means if a patient with stage 2 unfavorable Hodgkin's lymphoma and he is receiving 4 cycles of chemotherapy, whether it can be BIACOP or ABVD, followed by 30 grays of radiation, there is no difference in progression-free survival. However, if you see the second graph, so if you see the second graph, so this is the first graph. If you receive 30 grays, there is no difference in progression-free survival. Whereas if the same patient receives 20 grays of radiation after end of an ABVD or BIACOP, so in the 20 gray arm, if you see the BIACOP is performing better when compared to ABVD. So that is one first important point you have to know. So if you give 30 grays, there is no difference between BIACOP and ABVD. Where, however, if you give 20 gray, there is a difference. BIACOP is performing better. And even if you see the patients who are receiving ABVD and you are giving only 30 gray versus 20 gray. So 20 grays are performing inferior when compared to 30 gray. Means with ABVD, we always have to give 30 gray in an unfavorable Hodgkin's lymphoma basing on this study. Whereas if you want to give BIACOP, 20 gray is also fine when compared to 30 gray. So overall, what are the outcomes of this study? This study shows that, see, in summary, HDN trial presents here is BIACOP was more toxic. However, ABVD 4 cycles is equally effective as BIACOP 4 cycles. Means from this trial, we can inform that we can give 4 cycles of ABVD followed by radiotherapy for patients with unfavorable Hodgkin's lymphoma, early Hodgkin's lymphoma. So then, however, we know that radiation is associated with significant short-term and long-term complication. Whether we can give away radiation in patients who are having a good response. So that was studied in an H10 trial. So this is having favorable arm and also unfavorable randomization was there. So I'll discuss about the unfavorable. So here the patients were given 2 ABVD. The control arm is standard of care, that is 4 ABVD followed by radiation. And the control and the experimental arm is they have given 2 ABVD and they have done after 2 ABVDs, they have done a PET CT. If a PET CT was negative, they want to avoid radiotherapy and they have given 4 cycles of ABVD, total 6 cycles. If PET CT is positive, means they are responding poorer, they are escalated to BIACOP, to escalated BIACOPs and INRT. So again, if you see, this is a favorable arm and this is an unfavorable arm. So our patient is having an unfavorable. This is a non-inferiority trial. So the endpoint is avoiding radiation is non-inferiority in this study is not met. So still radiation has to be given in both the arms, H10, that is favorable arm and also unfavorable arm. And even if the patient having an end of treatment PET positive, the interim PET positive, that is after 2 cycles PET positive, that was compared with an ABVD and an escalated BIACOP. On the long-term follow-up, there is no significant difference in the progression-free survival also. At 5 years, there was a difference, but at 10 years follow-up, that difference was lost. So even PET CT of interim PET CT is positive also, escalating to BIACOP is not shown improvement in progression-free survival. So from this trial, still 4 cycles of ABVD followed by radiotherapy is standard of care. So coming to the other PET-adopted therapy, that is giving 2 cycles of the standard of care, 2 cycles of this is 2+2 design, that is 4 cycles, 2 cycles of BIACOP and 2 cycles of ABVD. This comes from HD14 trial. So this followed by radiation. And in the control arm, they have given 2 cycles of escalated BIACOP and ABVD followed by PET CT. And if PET CT is negative, they avoided radiation, and PET CT is positive, they have given radiation. Whether PET-guided approach is better than the standard of care or not in 2+2 chemotherapy design. So that was answered in this HD17 trial. And this is the trial that has met his endpoint, that is non-inferiority endpoint was met. So basing on this evidence, we can avoid radiation if you are able to deliver 2 cycles of escalated BIACOP plus 2 cycles of ABVD. Followed by, if PET is negative, you can avoid radiotherapy. So till now, we have discussed only the chemotherapy trials. So one thing is, if you are giving ABVD, 4 cycles of ABVD followed by radiotherapy, and if you can able to deliver a 2+2 design, there is 2 cycles of escalated BIACOP and 2 cycles of ABVD. In PET negative patients, we can avoid radiotherapy. That is from the HD17 trial. So what are the role of novel agents like brentuximab vedotin and nivolumab in the early Hodgkin's lymphoma. So this is there is no phase 3 phase 3 trials with brentuximab vedotin and nivolumab in this era, in this subset of patients, that is early stage Hodgkin's lymphoma. However, we are having a phase 2 trials, phase 2 randomized control trials. This is a breach trial where patients were given 4 cycles of brentuximab vedotin followed by radiotherapy, and it was compared with ABVD, followed 4 cycles of ABVD followed by radiotherapy. So this is an 2:1 design. And we know that as it is a phase 2 trial, the endpoint is also not that much strong. That is interim PET-CT response is the endpoint. However, the study has met the interim PET-CT rates were better with brentuximab vedotin when compared to ABVD. That is a difference of about 7%. And if you see, brentuximab vedotin patients are having a better progression-free survival here when compared to ABVD. And even in in this trial, after 2 cycles, PET was done, but modification was not done. But interim PET positive patients, in the positive patients and negative patients, interim PET positive patients, as we all know, that it is associated with poorer survival when compared to PET negative patients. And in the patients who are having an interim PET positive, where brentuximab vedotin has fared better. The progression-free survival, we can see, if you see here, it is nearly 98 versus 92%. Whereas in patients who are having an PET positive, that in between brentuximab vedotin and ABVD arm, it is around 90 and 80, 90 and it was around 90 and 80%. So still, in the patients who are having an PET positive, brentuximab vedotin fare better. And here another important novel prognostic marker that has been identified in this trial is metabolic tumor volume. So according to the metabolic tumor volume, also in early stage unfavorable Hodgkin's lymphoma, it is prognostic. Means the patients who are having a higher tumor metabolic volume are having a poorer progression-free survival, here the red one, when compared to the patients who are having a lesser tumor metabolic volume. So these are the takeaways. This is not a practice-changing trend, but it is one of the options because it is in phase. It is one of the options where you cannot able to deliver escalated PCOP or ABVD, or if a patient prefers for a novel agents. Coming to the nivolumab. So this is an interesting design. Here you can see it was not a randomization between an nivo-AVD versus ABVD. This is also a phase 2 trial in unfavorable Hodgkin's lymphoma. So here these patients were randomized to 2 different schedules of nivo-AVD. So the first, the arm A received 4 cycles of nivo-AVD followed by radiotherapy. Whereas in arm B, there are 4 doses of nivolumab was delivered prior, followed by 2 cycles of nivo-AVD, and further doses of AVD were given. So total 4 cycles of AVD, but there is a nivolumab was delivered prior to AVD and followed by radiotherapy. And what this trial has shown is, if you see at 3 years, the progression-free survival was almost nearly 100% in both arms, nearly. So it is 100% in the arm A and 98% in the arm B. So this is very exciting to see these kind of graphs in patients with an early Hodgkin's lymphoma, and overall survival nearly 100%. So these novel agents are promising, but yet they are not practice changing because they are all phase 2 trials. So what we have done with this patient? So our patient is 22-year-old. So he is having an early stage Hodgkin's lymphoma, which is unfavorable. So we treated him with 4 cycles of ABVD followed by radiotherapy based on an HD11 trial. We are not able to deliver. So we are not able to deliver. We are concerned with PCOP because of the higher toxicities. That is an gonadal toxicity. He's an younger patient and also secondary leukemias. That's why we didn't go ahead with an HD17 trial. Even though 2+2 design, we can avoid radiotherapy. And the H10U also, because non-inferiority was not met, we cannot able to avoid radiotherapy in this patient. And NIVO-AHL trial and breach trials, yes, they are exciting. They are showing an promising results, but we have to wait for an phase 3 data. Still, they are phase 2 trials, and this patient, our patients, like this patient is is utilizing the government credit. He is not he's having an financial issues also. So that's why we are also not able to deliver these novel agents for this patient. So coming to this, coming to the what are the guidelines that are recommending? This is the ESMO guidelines. So early stage favorable patients, we will use ABVD 4 cycles followed by ISRT. This is basing on the HD10 trial. Unfavorable early stage patient, so younger patients less than 60 years as our patient. There are two recommendations. One is 4 cycles of ABVD followed by ISRT, that is based on HD11. And another one is 2 cycles, 2 plus 2 design, that is 2 cycles of BACOP followed by 2 cycles of ABVD. And then based on the PET, if it is negative, you can follow up. If it is positive, you can use radiotherapy. So this is based on the HD17 trial. Okay, coming to the next second case. So this is also one of the challenging case which we have seen recently. So she is a 75-year-old lady with comorbidities of hypertension and type 2 diabetes mellitus. The first thing is she presented with an 1-month history of fever with associated with non-productive cough, and she is also having an exertional dyspnea. For this complaint, she was admitted and evaluated at an outside hospital, and they thought a diagnosis of an autoimmune hemolytic anemia, and she received 3 doses of IV pulse methylprednisolone. And after that, during that time evaluation only, they have shown to an hematologist there, and they have asked for after clinical examination, they have asked for an PET-CT. So the PET-CT was showing an hepatosplenomegaly with FDG uptake in the spleen, and also she is having an multiple lymph nodes, infra and supradiaphragmatic lymph node, and she is also having an anemia of 6.2. That's why she received all this thing. Apart from bone marrow, right supraclavicular lymph node excision biopsy was done, and the outside report, they reported as a non-Hodgkin's lymphoma, that is PTCL. There is peripheral T-cell lymphoma. So with this background, she came to us. On examination, she is having an bilateral cervical lymphadenopathy, and her performance status was very poor. 75-year-old lady with comorbidities and poor performance status, and hemogram is showing an pancytopenia with a hemoglobin of 6.2 and platelets were around bicytopenia, sorry. So it was hemoglobin of 6.2 and platelets of around 90,000. So with that background report of peripheral T-cell lymphoma, we started her on prephase. So one thing which I want to stress here is prephase is very important, especially for our frail patients. So don't start with an full doses of ABVD or Nevo-AVD or something, or BV-AVD in these frail patients. First, we have to make these patients suitable for an systemic therapy. So prephase will help in controlling the disease and improving the performance status of the patient. So we gave her prephase with an prednisolone and cyclophosphamide, and following that, her performance status improved. She was initially bedridden. Now she is able to sit in a wheelchair, and with the support, she is able to walk. And the second most important thing, what we have to keep in mind is always review the reports. So we have reviewed the biopsy again at our center, and now it was found to be classical Hodgkin's lymphoma. So these two are important practical points. And then the next important thing is her Hessen-Clever score, that is IPS score, is 4 high. That is 4 by 7. And her bone marrow, even though she is having cytopenias, anemia and thrombocytopenia, bone marrow was not involved. So she is having however, she is having an hepatosplenomegaly with FDG uptake. So she is having a stage 4 or low advanced Hodgkin's lymphoma because of the hepatic involvement. So, however, how we have to treat this patient? Because we know that Rathel's approach is there, AHL approach. These are the 5 important trials that have changed the landscape of management of an advanced Hodgkin's lymphoma. But where my patient fits in this all trials, if you see, there are only 3 trials that included elderly patients. But one important caveat is all these patients must have a good organ function, and they have to be in a shape to receive the ABVD or Nevo-AVD or BV-AVD. So, but my patient is not having those features. So how we have to treat this patient? For example, so Rathel's, if you see, more than 18 years, but they have to be fit to receive the full course of combination chemotherapy. My patient is not fitting into Rathel. And AHL, definitely, it is only for an younger patients. And German Hodgkin study group HD21, that is Placard. It is also for younger patients. And echelon one, that is BVAVD versus versus ABVD. It has included the patients more than 60 years for 25%, but they are having a good good performance status, good organ function, and they again have to they are fit to receive a full combination therapy. Whereas SWOG, that is DOAVD versus BVAVD. This also included more than 60 years, 10% of the 10 to 15% of the patients were there. Again, they are fit patients, but I cannot able to apply any of these trials to my patients. So how we treat these patients? So the first most important thing, if an elderly Hodgkin's lymphoma comes to you, the first thing what we have to do is the geriatric assessment. So geriatric assessment, multiple scores are available, but what we have to keep in mind is doing a geriatric assessment is important. So for example, what are the components we have to see in a geriatric assessment is what is the performance status, nutritional status, mental health, social support, cognitive function, comorbidities, all these 6 parameters has to be comprehensively evaluated for a patient with an elderly Hodgkin's lymphoma. So once after doing this comprehensive assessment, and strong consideration for prephase therapy is recommended if a patient, especially for a patient who are having a poor performance status or not yet fit for a full doses of combination therapy. So basing on these geriatric assessment, we will characterize the patient whether they're going to be fit for therapy or unfit for therapy. So usually the criteria that they will be you will see is activities of daily living, like whether they are able to do bath, whether they are where they are able to do their daily routine activities without help or with help, and instrumental activities of daily living like going to grocery store, or they can able to cook or not, or they can able to clean the floor or not. So and again apart from that, what is if they're having a comorbidities, what is the cumulative illness rating scale geriatric scores. So all these things we'll see. So the crux is assess the patient, the most important elderly patient, do an geriatric assessment, and then decide whether the patient is able to tolerate the therapy or not, that is fit or unfit or frail. So that is the crux of this thing. So if you fit for anthracycline based combination therapy, then these are the 3 options we know. So as I previously discussed, NIVO-AVD basing on the SWOG trial, BV-AVD that is also basing on the echelon 1 and AVD. So this AVD is a newer evidence that I will discuss in the further slides. So first thing is echelon 1 I want to discuss, where brentuximab vedotin with adriamycin, vinblastine and dacarbazine was compared with ABVD. So here so this is for a fit patient only. So if you see more than 60 years, so which is my patient age. So there is no, but this is a subgroup analysis. It is not powered for this one, but the forest plot was showing that it may not be beneficial for elderly patients. So BVAVD versus ABVD, there is no much difference. For an elderly patient, it is a subgroup analysis. It is an hypothesis generating. Again, it is not stratified for that one. So if you see, however, the overall results, if you see, there is an improvement in progression-free survival. There is also improvement in overall survival. But whether this therapy is going to benefit my patient or not, subgroup analysis is not showing much of benefit for my patient. Again, NIVO-AVD versus BV-AVD, that is the SWOG trial. So again, SWOG trial, this is the practice-changing trial. Currently, fit patients will prefer to give NIVO-AVD with an improvement in a 3-year progression-free survival also now. So there is a nearly 10% difference in a progression-free survival at 2 years, and that is maintained at 3 years also. In the recent ASH 2025, the NIVO-AVD is 91% and BV-AVD is 82%. And there is no much difference in an overall survival for now. But interesting thing is, there is an improvement in progression-free survival in all the subgroups, irrespective of the age. More than 60 years, hazard ratio, if you see, it is 0.3%. And other age groups also, there is an improvement in progression-free survival. And even 4 to 7, as my patient is having an IPS score of 4, even in that subgroup also, there is an improvement in progression-free survival. Stage 4, again, improvement in progression-free survival. Irrespective of B symptoms present or not, in all subgroups, there is an improvement in progression-free survival. And which subgroup has shown improvement in overall survival? So NIVO-AVD versus BV-AVD in the elderly age group, that is more than 60 years. If you see here, there is as you know, previously there is an improvement in progression-free survival. So the blue line is nivolumab and the red line is brentuximab. It is around BV-AVD is 64% and nivo-AVD is 89%. And there is also an improvement in an overall survival in this subgroup of patients. So the overall survival here, it is 96 versus 85%. So the another important crux is of even apart from showing an improvement in an progression-free survival and overall survival over brentuximab vedotin and AVD, that is BV-AVD. So it is also well tolerated, which is very important if you are treating a patient, elderly patients with an Hodgkin's lymphoma. So nivolumab with AVD is not only improving the survival, but it is also well tolerated than brentuximab vedotin AVD. So that is another important takeaway from this trial. So another important thing is what we have to do if a patient fit but cannot afford brentuximab vedotin or nivo-AVD. So nivo-AVD is the preferred one, or the second option can be an brentuximab vedotin with AVD. But what we have to do for patients who are not able to afford all these things. So this is the recent data from an registry. So the yellow line represents AVD. This is nearly around 1,500 patients data from a Norwegian countries. So the yellow line is of AVD. This is an overall survival, not an progression-free survival. And the blue line is ABVD. The last two lines represent CHOP and other regimens. So in an elderly population, more than 60 years, when you give AVD, it is performing better than ABVD. So that is another important point from this trial. So it is not always mandatory to give ABVD. So you can avoid bleomycin for the patients who are having an comorbidities and where you are not able to deliver bleomycin. It is not wrong in doing so. Even AVD is basing on this trial, and AVD has shown superior survival when compared to ABVD. So what we have to do for my patients who is not fit for an anthracycline based anthracycline based systemic therapy. So the right answer is there is no standard of care for this patient. So we may consider giving an immunotherapy single agent or brentuximab vedotin single agent, or a combination of an brentuximab vedotin or nivolumab, or a combination of nivolumab with the chemotherapy or brentuximab with chemotherapy. So currently there is no standard of care for this patient. So in a nutshell, if a patient is frail, these are combination therapies were there. In the next slide, so how we have to do is we have to see a comprehensive geriatric assessment. Along with that one, the good supportive care is very important for this patient. Don't hesitate to give growth factor support and prophylaxis for an infection if required. Then apart from that, prephase is very important to optimize the patients for an further treatment, and dose adjustment or scheduling are recommended according to the toxicities. So if a patient is fit, unfit or frail, it has to be an individualized based therapy. There is no standard of care. It has to be an individualized based therapy. So some of the therapies are BV with Nivo, as I told previously, or single agents, BV with dacarbazine or BV alone. So if a patient able to tolerate anthracycline, maybe in that situation, anthracycline based therapy can be considered. So what we have done for this patient? So we have given nivolumab with low dose nivolumab along with AVD with 50% dose along with GCSF support. She surprisingly she has completed all her 12 cycles of Nivo AVD. And one interesting thing is, as we are delivering the Nivo AVD, there is we have seen an improvement in an performance status and improvement in an activities of daily living also. So now after 6 cycles of Nivo AVD, her PET CT is also showing a very good response. So take home message for this elderly patient is, if a patient is fit for therapy, go with a standard of care. If a patient is not fit for therapy, we have to individualize the treatment. And when you are treating an elderly patient with an Hodgkin's lymphoma, always geriatric assessment is very important. Apart from that, supportive care is very important. Don't hesitate to give an prophylaxis for an infections, GCSF support if required, and don't hesitate to modify the doses if they are having significant toxicities. Whereas for an early Hodgkin's lymphoma, unfavorable, we can give 4 cycles. We treated this patient with 4 cycles of ABVD with radiotherapy. If you are able to deliver escalated BCOP, 2 cycles of escalated BCOP, plus 2 cycles of ABVD, followed by PET-CT. If negative, then you can avoid radiation also. Thank you.
Thank you, sir. Thank you for your excellent presentation. I request participant to post their question in the chat box, and I will direct them to the respective faculty.
Sure.
I think there is a question. How frequently is everyone using ESC?
Yeah, so I am not using escalated VCOP for patients with an Hodgkin's lymphoma unless they are having an advanced Hodgkin's lymphoma. Raffles approach was used, and post 2 cycles of ABVD is having an PET positive disease. So only in that condition, I am using an escalated VCOP. Whereas for an early Hodgkin's lymphoma, I am not using escalated VCOP. But still, that is an option based on HD17 trial. And whoever I know also, they are not using an escalated VCOP apart from that Rathels approach.
Any other question is there?
Yeah, instead of escalated VCOP, actually I am using VCOP 14, not an escalated VCOP.
Thank you, sir. Thank you so much. As we come to the end of today's session, I would like to extend my sincere thanks to all our speakers, panelists, and participants for making this webinar highly informative and engaging. We hope today's discussion have provided valuable insight into evolving treatment strategies in hemato-oncology. All the participants will be receiving certificate 2 to 3 working days to your registered mail ID. On behalf of IAIO, thank you all for joining us. We look forward to your participation in our future academic programs. Have a wonderful evening and stay safe. Thank you. Thank you, everyone. Thank you, sir.
Thank you.